My name is Rick Kronick. I'm a professor in the Herbert Wertheim School of Public Health at UC San Diego and a member of the consulting team that is providing support to Secretary Galley and the Healthy California for All commissioners as they work at deliberating about how unified financing in California might be implemented. More than 30 years ago, I was co-author of an article that described healthcare in the United States as a paradox of excess and deprivation. Although we have made substantial progress with the Affordable Care Act, in many ways that description is even more apt today than it was in 1989. As described in the environmental report that the Commission released last year, the healthcare system in California and the United States is lavish and expensive, but there are still millions of people in California and tens of millions nationwide who do not have timely access to care that would clearly be beneficial. We pay high prices for healthcare services, we waste lots of money on administrative overhead, and we spend lots of money on low-value services. In California, progress has been made in creating systems of care in which physicians and other healthcare providers work at figuring out how to improve the health of the population and how to deliver care that is well coordinated and patient-centered, particularly for patients most in need. But there is a long way to go in achieving these goals. The dominant feature of healthcare financing in California, as in the rest of the nation, is fragmentation. Some people are covered by Medicare, some by Medi-Cal, some by employer-sponsored insurance, and some through Covered California or the individual market, and millions are still uninsured. It has long been clear to almost everyone who thinks about healthcare financing that fragmented financing does not serve us well. As documented in the Commission's environmental report, fragmentation is the root cause of the glaring inequities in California's healthcare, and fragmentation is also a key obstacle to improving quality and efficiency. But even though the ills created by fragmentation are clear, we face the daunting problem of figuring out how to end fragmentation and how to create a system of unified financing. The status quo, especially in an industry that accounts for 18% of the nation's economy, is understandably very hard to change. And the status quo is even harder to change because healthcare is so personal and important to us. And many people are understandably concerned that changes in how we get coverage will result in changes that make the healthcare we receive worse, not better. A necessary condition to make change possible is to have a well-developed blueprint for how unified financing would actually be implemented in California. At a previous commission meeting, one of the commissioners said that he had the sense that unified financing was probably a good idea, but didn't really know in any level of specificity how it would work. The legislature, in establishing the commission, tasked commissioners with producing a report with design options for unified financing. To support the commission in accomplishing this task of designing unified financing, the consulting team has produced estimates of the effects of a variety of scenarios for unified financing on healthcare coverage, costs, and equity. It is my pleasure to present the results of that work today. I want to start by acknowledging the talented and hardworking team that produced the estimates I will be presenting, and particularly to thank the multi-talented Laura Lucia from the UC Berkeley Labor Center, who was the backbone of that effort. I'll start with a definition of what we mean by unified financing. We mean a system in which all Californians are covered for a comprehensive package of benefits by virtue of being Californians. Under unified financing, the distinctions among Medicare, Medi-Cal, employer-sponsored insurance, and the individual market would be eliminated. Unlike the status quo, whether someone is covered and what they are covered for would not depend on a person's age, employment status, income, disability status, or other characteristics. To achieve unified financing, the federal government would need to agree to change many rules that govern the Medicare and Medi-Cal programs, and would need to write checks to the state of California in lieu of the money that would otherwise have been used to support Medicare and Medi-Cal beneficiaries. Even a friendly Biden administration could not agree to make these changes on its own through a waiver process. Changes in federal law would be needed, certainly to allow the participation of Medicare and almost certainly for Medicaid as well. In talks with commissioners prior to this meeting, many commissioners told us that they thought it was extremely unlikely that Congress would enact anytime soon the statutory changes that would be needed to allow unified financing to be implemented in California. But many commissioners also acknowledged a chicken and egg problem. While they thought it unlikely that Congress will change federal law to allow California to adopt unified financing, there is virtually no chance that Congress would do so unless California has a well-developed blueprint for how unified financing would be implemented. And thus, even many of the commissioners who were skeptical that developing such a blueprint would result in positive change anytime soon were supportive of the notion that developing such a blueprint could prove useful in the event that an opportunity for congressional action were to present itself. For those who may be impatient and or those who don't have the time and energy or to sit through this entire presentation, I will start with a summary of the results. Under unified financing, all Californians would be covered for a comprehensive package of services. Under unified financing, care would be more equitably delivered because access to healthcare providers and systems would be more equal, and because benefits would be standardized at levels that assure that cost rarely deters care seeking. Under many scenarios for unified financing, aggregate health spending in California would be slightly lower in the first few years than under the status quo. And under nearly all scenarios estimated for unified financing, aggregate spending would be substantially lower over a 10-year period than in the status quo, if, as expected, health spending grows more slowly under unified financing than under the status quo. In short, and no surprise given my earlier comments, unified financing would have many salutary advantages over the status quo system of fragmented financing. We provide an overview of the rest of this presentation. I will start with describing assumptions about how unified financing might be implemented at a very high level, follow with some information about our approach to estimating the effects of unified financing, present results, and then very briefly provide a description of areas in which decisions would be needed about how to implement unified financing. Let me start with the assumptions. There are many ways in which unified financing could be designed and implemented. I am going to describe at a very high level a few scenarios for covered benefits, for cost sharing, the level of provider payment, and the role, if any, for intermediaries, and the rate of growth of spending over time. The purpose of analyzing these scenarios is to provide some grounding for the conversation that commissioners will be conducting moving forward. There are many other scenarios that could be analyzed and that we are open to analyzing as time and resources permit. In consultation with CHHS, we have chosen the scenarios for which we're presenting results today on the basis that they will provide a useful starting point for discussion. I emphasize that these scenarios are described at a very high level without specifying the important details of exactly how any provider would be paid, or how accountability mechanisms would work, or how a transition from fragmented to unified financing might actually be accomplished. I expect those topics and others will be the subject of subsequent discussion among commissioners. Let me start with the covered benefits. We provide estimates for a comprehensive package of benefits, including essential health benefits as defined in the Affordable Care Act, with the addition of coverage for adult dental services. We also provide estimates for the addition of long-term services and supports, including both institutional and non-institutional long-term care. We provide estimates for two scenarios on patient cost sharing. First, a scenario with no cost sharing, and second, a scenario with income-related cost sharing. In the second scenario, there'd be no cost sharing for households earning below 138% of the federal poverty level, 94% actuarial value, meaning that insurance or the unified financing system would cover 94% of the average cost, and households between 138 to 400% of the federal poverty level would cover 6% on average of costs. In Covered California, 94% silver plan has a $5 copay for office visits, a $75 deductible, and a $1,000 out-of-pocket maximum. And then for families in households above 400% of the federal poverty level, 85% actuarial value. And again, in Covered California, this would be similar to a plan that might have a $15 primary care copay, $25 for specialists, $1,400 deductible, $2,800 maximum out of pocket. On level of provider payments, we provide estimates for a scenario in which aggregate payments to hospitals, physicians, and other healthcare providers would be at levels equal to the weighted average of current Medicare, Medi-Cal, and employer-sponsored insurance payments, minus estimated reductions due to reduced billing and insurance-related costs. We could certainly provide estimates for other scenarios as well. Some have suggested proposals that call for reductions in provider payment beyond the billing and insurance-related savings that we are assuming in this scenario. We thought it would be useful to illustrate results in a scenario in which healthcare providers are, on average, basically left whole. In this scenario, we assume that drug payment policies, such as international reference pricing and/or aggressive negotiation for prices as conducted by the Veterans Administration, would be implemented as part of unified financing. On the role, if any, for intermediaries, we again provide estimates for two scenarios. First, a scenario similar to Canada, in which Californians could choose to receive services from any licensed physician or hospital. In this scenario, payments to physicians and other non-institutional providers would largely be made on a fee-for-service basis. Hospitals would be paid based on global budgets. And the second scenario, somewhat similar to Medicare Advantage, Covered California, and somewhat similar to models in Germany and the Netherlands, in which all Californians would enroll in a health plan or a health system. Each plan or system would offer the same set of benefits and the same cost sharing, if cost sharing were used. Plans and systems would be paid a risk-adjusted capitation. Unlike the status quo, where we have health plans that differ widely, there'd be much more uniformity in covered benefits, provider payment rates, and cost sharing across health plans or health systems. For the rate of growth of health spending, we also provide estimates for two scenarios, one in which health spending would grow at 0.5% per year more slowly than the projected rate of growth in national health expenditures, and second, a scenario in which health spending would grow at the projected rate of growth of the gross domestic product, which is approximately 1.3% more slowly than the projected rate of growth of health spending. And a reduction in the rate of spending growth could be accomplished by curbing rates of increases in prices and/or by reducing low-value care fraud, and abuse. Again, other scenarios could certainly be modeled. Unified financing provides the Unified Financing Authority a price lever that does not exist in the status quo. If spending grows more quickly than revenues, the Unified Financing Authority could, in principle, reduce prices. Far preferable, of course, would be to reduce spending growth by reducing low-valued care and reducing waste, fraud, and abuse. Unified financing certainly provides opportunities to make progress in those areas, but there are no guarantees. And the price lever and global budget restraint is a fallback mechanism, although one that would raise concerns about the ability to attract and retain a high-quality workforce. I'm going to move now to describing briefly our approach to estimating the effects of unified financing. We used evidence generated by health services research to estimate the effects of unified financing on healthcare utilization, on spending, and select other outcomes. We rely heavily on estimates made by the Congressional Budget Office, adapted to the unique healthcare environment in California. A comment about what we can and can't estimate. We are unable to directly estimate the effects of unified financing on many important outcomes, including how safe will care be, how timely will care be delivered. We'll say something about efficiency and equity, but only partial there. Nothing about whether care will be any more patient-centered under unified financing than under our current fragmented financing system. The limitations of health services research, as well as the design of unified financing, make it not possible to provide estimates of the effects on many important outcomes. And all the estimates that I will be presenting, as are all estimates of unified financing that anyone presents, are subject to substantial uncertainty. Although decades of health services research provide some guidance, we simply do not know with any certainty how patients and providers will respond to the markedly changed environment envisioned in unified financing. I've talked about what we're not estimating. Some brief mention of what we are estimating. We estimate the effects of increase in health spending from insuring the uninsured, from improving coverage for the currently underinsured under both a no cost sharing scenario and the scenario where there is cost sharing. We estimate reductions in billing and insurance related costs at hospitals, physicians, and other healthcare providers, again, under two scenarios of direct payment and the scenario where health plans and health systems are used as intermediaries. Reductions in health insurer administrative costs under these scenarios, reductions in healthcare spending as a result of lower prices for pharmaceuticals, the increase in spending from benefit enhancements, change in health spending due to less use of capitation in the scenario based on direct payment. I'll talk more about that in a few slides. Costs for funding needed reserves, and costs to facilitate a transition for workers in billing and insurance related functions who are likely to lose their jobs. Okay, results, what people have been waiting for. I'm first going to present results on aggregate health spending under a variety of scenarios, and then present results on other outcomes. Under the status quo, health spending is projected to be $517 billion in 2022, or 15.4% of the gross state product. If unified financing were fully implemented in 2022, under the scenario with direct payment to providers, no cost sharing for patients, and without expanding long-term services and support benefits, we estimate that health spending would be slightly lower than it would be under the status quo, a difference of a few $billion or about 0.1% of gross state product. In a few slides, I'll show the pluses and minuses that underlie this estimate, but the short version of the story is that estimated increases in utilization and spending from insuring the uninsured, improving coverage for the underinsured, and from other aspects of unified financing are more than offset, slightly more than offset by savings from lower drug prices and lower administrative costs. We also estimate that spending would be very similar in a scenario that uses health plans or health systems as intermediaries as it would be in the scenario that relies on direct payments to providers. Again, in a few slides, I'll show the pluses and minuses, but the short story is that we expect administrative costs will be lower in the direct payment scenario, but that utilization will be somewhat higher, and those two factors will largely balance each other. The decision about whether there will be patient cost sharing does affect estimated aggregate spending somewhat. As you can see on this slide, estimated spending in the scenario with some patient cost sharing is 14.6% of gross state product, about 5% or $25 billion lower than in this scenario without cost sharing. Unlike in the status quo, in this scenario, cost sharing would be strongly related to income. In the status quo, higher income people with employer-sponsored insurance have better benefits and lower out-of-pocket costs than lower income employees. In the unified financing scenario, that story would be reversed, with much less cost sharing for lower income Californians and moderate levels of cost sharing for higher income Californians. Relying entirely on an estimate from the Congressional Budget Office, estimated spending with an expanded long-term services and supports benefit would be somewhat higher, again about 5% of health spending or $25 billion, than in a scenario without expanded LTSS benefits. There is even more uncertainty in this estimate than in others I have presented, both because the Commission has not discussed at all how an expanded LTSS benefit might be designed, but also because we have very little evidence about how providers and patients would respond to an expanded benefit. Estimates on the preceding slides were for 2022. This slide shows estimated spending 10 years after program implementation. Under the status quo, health spending is projected to increase from 15.4% of gross state product to 17.1%. Under unified financing, if spending grows at the rate of growth of the rest of the economy, it would remain at 15.3% of gross state product. If it grows 0.5% per year more slowly than projected spending nationwide, it would be 16.3% of gross state product in this scenario with no cost sharing and without LTSS expansion, still substantially less than the projections for the status quo. Note that even under the status quo, health spending as a share of the economy is much lower in California than the national average. The 15.4% estimate for California for 2022 compares to an estimate of 18.4% for the nation in 2022. The lower fraction in California is a result of the fact that our health spending per capita is pretty similar to the national average, but gross state product per capita is much higher than average. This slide shows estimates for the scenario with expanded long-term services and supports, and shows that with this expansion and with no cost sharing for patients, we either would be spending significantly less in 2031 than under the status quo, or approximately the same level as under the status quo, depending on which scenario we're assuming for the rate of growth of healthcare spending. Two slides now on the pluses and minuses. I showed earlier the estimate that spending would be slightly lower under the direct payment scenario than under the status quo. 15.3% for direct payment, 15.4% of gross state product for the status quo. This slide shows the components of that estimate. We are estimating that unified financing would result in a 40% reduction in the prices paid for prescription drugs, which translates into close to a 6% reduction in overall health spending. Similar to a variety of other analyses, we are estimating substantial reductions in payer administrative costs due to the elimination of private insurance, as well as substantial reductions in billing and insurance-related costs for hospitals and physicians. Largely balancing these savings, we estimate a small increase in spending for insuring currently uninsured people, a larger increase in spending for eliminating cost sharing, and an increase in spending from unwinding managed care, which I'll talk about more on the next slide. We estimate a small increase in spending to fund reserves, and as I said earlier, a net change in spending pretty close to zero. I also showed earlier the estimate that health spending would be similar in the direct payment scenario and in the scenario with the use of health plans or health systems as intermediaries. This slide shows the components of that estimate. Under direct payment, we expect that utilization and spending will increase because of the unwinding of managed care. Evidence from the Integrated Healthcare Association California, as well as evidence from the Medicare Advantage program and other sectors, shows pretty clearly that healthcare utilization is lower when providers are paid a capitated amount than when they are paid on a fee-for-service basis. I expect that this estimate will be controversial for some, but consistent with estimates made by the Congressional Budget Office, we are estimating an increase in spending from unwinding managed care in the direct payment scenario. However, administrative savings would be lower in a scenario in which health plans or health systems are used as intermediaries than in the direct payment scenario, and we estimate that these two effects will largely balance each other. Before moving on to estimates of the effects of unified financing on outcomes other than healthcare spending, I want to comment on the estimates I've just presented. I'm sure that some analysts will think we have underestimated the savings from unified financing or perhaps overestimated the additional costs, and that health spending under unified financing will be substantially less than we've estimated here. Other analysts may well think the opposite, and that spending under unified financing will be larger than we have estimated. Similarly, some will think that direct payment must certainly cost less than using health plans as intermediaries because the administrative savings will be greater. And others will be sure that we've underestimated the costs under direct payment. I am hopeful that commissioners and the public will not overly focus and obsess on these estimates and not put too much effort into arguing about their accuracy. But the main task of the commission is to provide the governor and the legislature with design options for unified financing and to help those decision makers understand the implications of those options for access, cost, quality, and equity. There are certainly design options, for example, substantial reductions in provider payment rates that would result in larger estimated savings. It is also certainly the case that other analysts would produce different estimates of savings for the scenarios that we have analyzed. But imagine that this analysis, instead of estimating a very small savings in 2022 for a particular unified financing scenario, had estimated a 3% or perhaps even a 5% reduction in spending. Would that estimate change policymakers' judgment about the desirability or feasibility of implementing unified financing? I doubt it, although others might certainly come to different conclusions on this point. The next slides show estimates of the effects of unified financing on other outcomes of interest. Unified financing would result in universal coverage. No longer would millions of Californians be uninsured. The fraction of Californians with the usual sources of care would increase. The number of deaths would decline, although there's a fair amount of uncertainty about exactly how much. The number of Californians with at least one physician visit per year would increase by approximately 1 million, and the percentage of Californians reporting problems paying bills would decline. Similarly, the fraction of Californians who report experience an access problem because of costs would decline. Some of the beneficial effects shown on the last few slides could be achieved by achieving universal coverage without taking the extremely disruptive step of moving to unified financing. As an alternative to unified financing, California could build on our current fragmented financing system and achieve close to universal coverage while leaving the basic structure of Medicare, Medi-Cal, employer-sponsored insurance, and the individual market in place. To achieve universal coverage in the context of fragmented financing, California would need to extend affordable coverage options to residents who are undocumented, build on the Affordable Care Act subsidies, and likely increase the individual mandate penalty. But if the California legislature were willing to take these steps, many of the benefits of universal coverage shown on the previous slides could be achieved. But building on our current fragmented financing system cannot achieve many other benefits that are made possible by unified financing. Under fragmented financing, we will continue to waste lots of money in administrative costs. It will be difficult to restrain the rate of growth of health spending. And given the restrictions created by federal ERISA law, millions of Californians with employer-sponsored insurance will continue to face high out-of-pocket costs. Most fundamentally, the inequities that fragmented financing creates can only be addressed under unified financing. Under unified financing, access to care for Medi-Cal beneficiaries would increase substantially. In most of the state, the systems of care that serve Medi-Cal beneficiaries are quite separate from systems that serve other Californians. Although there are some advantages for beneficiaries in systems that are responsive to the special needs of low-income Californians, there would be arguably tremendous benefits to breaking down the barriers that lead to segregation of care for low-income Californians. As discussed previously, there'd be substantial reductions in the time and money that hospitals, physicians, patients, and payers spend on administrative activities. And the addition of adult dental benefits under unified financing would result in improvements in oral and arguably physical health. Finally, as I've mentioned previously, the tough work to design how unified financing might be implemented is the task in front of the Commission. I list on this slide some of the major areas in which design options are needed. The consultants and I look forward to listening to discussion among the commissioners about which of these areas or others they would prioritize for deeper dives, and to support those discussions by providing whatever information we can. To summarize, as has been shown in many other analyses, if the federal government, the California legislature, and the California electorate agreed to create unified financing, then it would be possible to cover all Californians, greatly increase health equity, not spend more money, and reduce the rate of growth of health spending over time. I should mention that a variety of changes to the California Constitution would be needed to allow California to implement unified financing, and that voter approval of those changes would be required. And as I've mentioned, many design decisions need to be made to understand how and how well unified financing would work in improving the safety, timeliness, equity, efficiency, and patient-centeredness of care, as well as in creating a sustainable financing system over time. On behalf of the consulting team, we look forward to answering questions that the commissioners and the public may have about the material I presented today, and to support the commission in its work moving forward. Thank you very much.